Hi, good afternoon, everyone. My name is Vishal Gupta. I'm one of the ICU specialists here at Nepean. So welcome to weekly advanced echo teaching. So today we will be talking about mitral valve stenosis. So in this talk, we will be, talking about the etiology, pathophysiology, and then how to do an echocardiographic assessment, and then how to assess the severity, and then we'll be discussing a few cases as well. The good thing is it's not very common. So, and this is one of the least frequent left-sided, single heart disease, and it's more common in the developing disease or developing countries, and around 10% of the left-sided disease in Europe in one of the studies, done a few years ago, and it's more common in females as compared to male 3:1 ratio. So 99% times it's a rheumatic heart disease, which is the cause of mitral valve stenosis. The second most common is the degenerative mitral valve disease, and mainly in that mechanism is the annular calcification. So other uncommon causes like infective endocarditis, sometimes congenital thrombus, some left atrial tumor like myxoma, and the lupus is also, can cause that. So first of all, rheumatic. So rheumatic, as we said, it's the most common, and main mechanism in that is the commissural fusion. So you can see here, so this is the commissural fusion you can see, and they could be caudal shortening and fusion. And you can see here that this is mainly the leaflet tips, which, it's affecting the rheumatic, mitral valve stenosis. And on the echo, it would look like there's a diastolic doming of the anterior mitral valve leaflet, or we can say it's a hockey stick appearance, which is a classical for rheumatic mitral valve stenosis. Whereas in the degenerative, mitral stenosis, the main lesion is the annular calcification. And it mainly affects the base of the leaflets. You can see the tip is not, affected. And because it's a degenerative disease, so that's why it's more common in the elderly patients. And in all the problems of the elderly population, like hypertension, atherosclerotic disease is the common association with this. So main way to differentiate between the rheumatic and the degenerative is, in the rheumatic, it's mainly the tips which is affected, whereas in the degenerative, it's mainly the base of the leaflet is, is affected. So now quick rapid fire in terms of the etiology of mitral stenosis. So in next few slides, I just want you guys to comment only on the mitral valve. So let's start, Hatim, with you. Can you just comment on the mitral valve for me?
So mitral valve doesn't look like it's opening adequately. It's heavily calcified, and definitely the outlet out of it, or at the leaflet level, is quite diminished. So I'd expect an element of stenosis here, given that the left ventricular function is intact. So definitely it's valvular pathology.
And which area is more affected, the tip or the base, and what do you think it's the etiology?
So it looks mainly the leaflet tips had been involved here, with more heavy calcification at the tips with very small orifice. So I'd expect it's having rheumatic disease at the underlying pathology.
Yeah, thank you. So it looks like it's rheumatic. So next one, Mark, for you, please.
So did you mean me, Marcus, or?
Yeah.
All right, sorry. So TOE image, obviously, not atrium, and we're looking at the mitral valve, anterior leaflet towards the LVOD, and the posterior leaflet towards the lateral wall. So we've definitely got calcification at the base of the valve, and the restricted movement of the tips of the leaflets, posterior and anterior leaflet, with reduced opening of the mitral valve.
So
and reduce mobility.
Calcification is the main pathology here, right?
Mm-hmm.
The tips are free and it's not affected. So it is mainly the base which is calcified.
Yeah.
So it's only degenerative mitral valve stenosis.
Mm-hmm.
Thank you. Ben, the next one is for you.
Yeah, no worries. So I'm looking at an apical 5-chamber. The patient's in sinus rhythm. It looks as though the base and the annulus of the mitral valve, from what I can see, looks heavily calcified with some bit of dropout behind it. I can't clearly see a good opening, and I can't see the tips. Left atrium in this view looks dilated.
Just the mitral valve.
Yeah, so I'd be more suspicious of this being atherosclerotic associated basal calcification, because I can't see the tips very well and the base looks quite calcified.
Yeah, this one is not straightforward. So, what happened in this case? So it looks like the tip is really, it's a thick and it was rheumatic in origin.
Right.
Even if it's the rheumatic in origin, you can have associated, calcification on top of that. That's what happened here.
Right, okay, yeah.
It was rheumatic in origin, so you can see the tip is also affected. It's not only the base.
Yep.
And on that superimposed calcification on the rheumatic valve.
Yep.
Okay. Samar, do you want to take this one? Samar, are you with me? I think we lost Samar. So Vijay, do you want to take this one?
Yeah, I'm just going to comment just on the mitral valve. It looks like there is a significant restriction related to the base. It looks quite calcified, and also the movement of the tips is quite restricted because the base is quite calcified, possibly a degenerative disease of the mitral valve.
Good, thank you. Next one, Samar, are you with me?
Yes, I am. Sorry, Vishal.
So next one, you can take this one.
Look, I'm not good at toes, so I believe this is a toe image. Is that correct?
Yes.
Yeah. So I can see that the anterior mitral valve, it's giving that hockey-stick appearance.
Yeah.
And there is calcification at the tips of the mitral valve, suggesting that's
thickening of the tip. That's a right terminology here.
Yeah. So it suggests that it's a rheumatic valve stenosis.
Yeah, perfect. Thank you. And last one, Hatim, for you.
So it's again an apical 4 chamber through a toe at 20 degrees. And this is again from the mitral valve perspective, there is heavy calcification at the base of both anterior posterior leaflet, more on the posterior leaflet, with reduced orifice opening. So likely to be degenerative.
Yeah, thank you. So as you can see, so it's not difficult to differentiate between the rheumatic versus degenerative mitral valve stenosis. Just if you pay a little bit of attention on the leaflets, you can easily differentiate between these two pathologies. So in terms of pathophysiology, sorry, give me a second. So there's a stenosis at the mitral valve. So this hole is getting smaller and smaller. So over the time, the left atrium has to push really hard. And so two things will happen here. So first thing, because there's not enough blood going into the left ventricle, so there's a decrease in left ventricle filling. And because of that, you may have smaller left ventricle cavity size or the normal size. And because the left atrium has to work really hard, so over the time, there would be left atrial dilatation. So that's very, very important and very common finding in mitral stenosis. And over the time, there would be increase in left atrial pressure. And with that, the pulmonary vessels have to work hard. So over the time, there would be pulmonary venous hypertension, which would give all the symptoms of mitral stenosis like congestion, pulmonary edema. And there would be right ventricle thickening, right ventricle dilation, and over the time there would be right ventricle failure. So that's how the pathophysiology of mitral stenosis is present in the clinical scenarios. So let's talk about that. How would we, do the echocardiographic assessment? So first off, M-Mode. I really like M-Mode, and I think we underuse M-Mode. So this is the M-Mode of mitral valve. This is the normal thing. So this is a normal valve. So you can see this is E, this is A, and this is the anterior valve leaflet, and this is the posterior mitral valve leaflet. And this is the opening of the mitral valve. And so this is normal. So always, C for E and A, and this is the mitral valve closer here. And sometimes if you have prolapse, you would see the prolapse here if there would be any. And in the mitral stenosis, so it depends whether you have the sinus rhythm or the patient is in atrial fibrillation. In the sinus rhythm, so you will, lose that typical E and A, but you will have this slow kind of features, and a little bit of A would superimpose on the E. But whereas in atrial fibrillation, because you don't have any A wave, so it will be simple slope. And you can see in the right side of the image, so this is the anterior mitral valve leaflet, this is the posterior leaflet, and this is the opening. So you can see this opening is been reduced, and based on this image, looks like it's a moderate stenosis. And just on the M-Mode, you can figure it out whether patient has significant stenosis or not. Then you will go for 2D mode, and as we discussed in the pathophysiology, so basically you will see the what kind of pathology at the mitral valve, whether it's a rheumatic or any thickening or calcification. Your left ventricle will be small size or normal size. You will have dilated left atrium, because left atrium is dilated, either transthoracic and definitely in the transesophageal. Look for the left atrial appendage clot or some thrombus. And pulmonary vessels will be dilated. There would be signs of pulmonary hypertension, and over the time there would be thickening of the right ventricle, and probably maybe dilation or the right ventricle dysfunction over the time. Then in the 2D mode, it's one of the very important measurement. So mitral valve area planimetry. So this is one of the most important parameters to measure in the mitral stenosis, because this is the only direct measurement of mitral valve area. And it has shown that it's the best correlation with the anatomical valve area. So normally if you're doing transthoracic, then in the parasternal short axis, or if you're doing TOE, then the transgastric short axis view, you can do the planimetry. And normally we do it in the mid-diastole. So zoomed image, optimize your gain setting, and make sure that you have good window. Then you can trace the mitral valve, and it's not much dependent on the flow, chamber compliance, and the heart rate. So as I said, parasternal short axis and transgastric short axis in 3D echo. So there was recently one, I think 4 or 5 years ago, there was one study published. So they compared all these 3 parameters, that whether there's a correlation between the planimetry in the parasternal short axis and TOE and the 3D echo. And it has shown whether 3D echo you can do on the transthoracic as well as transesophageal. So if you're using 3D echo, so that was the best parameter that was very well correlating with the anatomical mitral valve area. Because if you're doing using the 3D echo, so you can see, you can be 100% sure that you are at the mitral valve tips. But if you're just using your parasternal short axis, then you cannot be 100% sure whether you're measuring at the mitral valve at the tip or not. If you're a little bit proximal, then it will overestimate the mitral valve area. So that's why 3D echo is the best if you want to do the planimetry. So pitfalls. So of course you need good acoustic window. If you're not getting good pictures, you cannot do planimetry. And in the degenerative disease, because sometimes there's a severe calcification of the leaflet tips, and sometimes superimposed on the rheumatic pathology as well. So it would be very, very difficult or something impossible to work out what is what, and we cannot do planimetry in those cases. The other thing is because mitral stenosis is not very common. and we don't see it very often. So that's why, technical expertise is, is a problem, because we don't do it, on the routine basis, planimetry. And, you need to optimize your gain, because if you're overgained, then you can do underestimation of the area. And 3D thing we already discussed. Then color Doppler. So color Doppler, if there's a significant stenosis, so you can see there's a typical very, flame-shaped jet you would see here, which is a very classical of moderate to severe stenosis. And, look for that chaotic flow, or, lots of variance, or, this flame-shaped jet. And also, you would be looking for any coexisting valvular regurg as well. So after planimetry, this pressure half time is the second most important parameter, and this is level 1 recommendation to measure pressure half time. So on the x-axis, you can see this is the time and this is the velocity. So this is the time interval. So time interval between when your gradient was maximum and when it dropped down to half of the maximum value. And then we measure this time interval. And mainly, basically, you have E and A. You just need to trace your E wave, then you can get your pressure half time. And this is the formula of calculating your mitral valve area. So 220 divided by your pressure half time. So as you can see, mitral valve area is inversely proportional to your pressure half time. If your pressure half time is increasing, then your area is decreasing, which is suggests your severity. So pressure half time, you can get these two kinds of slope. So one is the linear slope, and which is simple. You just need to trace that, and you can get your pressure half time. But sometimes you get this non-linear slope, or we get a bimodal slope. Then sometimes it's very confusing where we should be measuring the pressure half time, because this is a slope. Either you can measure it here, or you can measure it here. But recommendation is that if you have bimodal slope, then you measure it mid-diastolic, because you can see the slope, the majority of slope is made by that much part. So that's why we don't do it here. So we just trace it this area. If you want to calculate in the bimodal slope, so mid-diastolic, is the point where you will measure your pressure half time. So pitfalls. Of course, you need good Doppler signal, because if you don't have good trace, you cannot measure your you cannot trace your pressure half time. So if patient is tachycardic, it means that your diastole will decrease, and it will affect your left atrial compliance as well. Aortic regurg. So aortic regurg, it's very interesting. So if you have acute aortic regurg, then it will shorten your pressure half time, and it means that it will overestimate the mitral valve area. So when I was preparing this talk, then I read few papers. So it's very interesting that aortic regurg has very variable effect on the pressure half time. So if it is acute regurg, and it will overestimate the mitral valve area. But if it's chronic, so what would happen over the time? That mainly it will, that over the time that left ventricle will be used to that aortic regurg, and there would be increase in left ventricle compliance, and that would offset the effect of aortic regurg. So my take-home message in terms of aortic regurg is that if it's acute, then pressure half time may not be accurate, and because it will overestimate the area. But if it's a chronic AR, then still we can take pressure half time parameter into account in assessing the mitral valve area. Then if your left atrial pressure is very high, then you will have very sharp E wave, which will affect your pressure half time measurement. And the same in terms of left atrial compliance, like tachycardia, post valvuloplasty, and fever, exercise. All these things will affect your left atrial compliance. And if patient is in fibrillation or any other arrhythmias, because it will again alter your timing of atrial contribution or atrial kick and E-wave configuration. And the last one we already discussed, non-linear pressure, which is a bimodal slope, which we already discussed, we measuring the mid-diastole. And then the third most important parameter to measure is again level 1 recommendation. So to check the mean pressure gradient. So based on the simplified Bernoulli equation, and you can use both pulse wave or the continuous wave, but continuous wave is preferred method because if sometimes your velocities are high, you may not be able to capture on the pulse wave. So that's why it's better to do on the continuous wave if you can. And mainly we do it in the apical 4-chamber, the same thing, good alignment, good Doppler angle, optimize your gain, and then just trace it. You don't measure the peak mitral velocity because that's dependent on the left atrial compliance and LV diastolic function, and which is very, very variable in the critically ill patients. The mean is, that's what we're after. And so I've shown it the both things. So if you just trace it like this, you're calculating your pressure half time, and if you're tracing the whole thing, you're calculating your mean gradient. It's almost the same kind of pitfalls. So again, you need good Doppler angle. Atrial fibrillation is a problem because there would be variation every beat. And again, it's dependent on flow conditions, heart rate, cardiac output, and also the coexisting mitral regurg. So there are a few other parameters which may be helpful, but we don't measure it on a routine basis. These are the level 2 recommendations. So first is the continuity equation, which we do for aortic stenosis. And the top things are the same, that LVOT diameter and your LVOT trace. So instead of aortic valve VTI, we just change it to mitral valve VTI. And then based on continuity equation, you can calculate your mitral valve area. But there's so many parameters and there's so many chances of error. So that's why it's not very accurate, and it's not, we don't do it routinely. But if you don't have other parameters, it can help you. If if parameters are not, there's a discrepancy between the other parameters, then you can use this one. The same with the PISA method. We don't do it routinely, and again, so many variables. And if you can see, there's a square, of the radius. So there's very high chances that there may be error. But again, if we don't have other parameters, this can be used. There's a WILKINS score has been mentioned, mainly talking about what kind of anatomy we have for the mitral valve. And mainly there are 4 parameters we talk in calculating the WILKINS score, which is the mobility, thickening, calcification, and subvalvular thickening. So minimum score is 4, maximum is 16. And WILKINS score is mainly to assess or mainly to guide the kind of treatment which patient would need. So if WILKINS score is less than 8, then patient may be suitable for percutaneous balloonoplasty. And if WILKINS score is more than 8, then patient would need valve replacement. And so as per ACE guidelines, so the severity of mitral stenosis, so less than 1 is severe, the valve area. Mean gradient less than 5 is mild, 5 to 10 is moderate, and more than 10 is severe. And of course, you need to check your pulmonary hypertension, and more than 50 comes in severe category. Interestingly, it's that pressure half time is not mentioned in the AC severity guidelines, but definitely it's level 1 recommendation. You need to take that into account as well. Then stress testing in mitral stenosis is very, very important. So whenever there's a discrepancy between resting echo findings and the clinical symptoms, you need to think about doing the stress testing. So we had one patient a few months ago. So that patient, young female patient, came with, I don't remember what was the indication of TT, But on that, we found that patient had mitral mean gradient around 8 to 9, and pressure out time was also around 210 or 200. But patient was completely asymptomatic. There were no symptoms at all. Then we, asked her to do a little bit of exercise, and then we did again repeated the echo, and the gradient increased, the pulmonary hypertension increased, and we referred that patient to the cardiologist for some kind of intervention. So whenever there's a discrepancy, think about doing the stress testing, and there are two main parameters we need to look into: whether your mean gradient is increasing more than 15, and your right ventricle systolic pressure is increasing more than 60. If you're meeting these two criteria, it means you need to refer your patient to a cardiologist. Okay, now there's a fun part. Hatim, do you want to take the first one?
Should be okay.
So 61-year-old lady, history of hypertension, diabetes, CCF, and presented with hypertension and acute renal failure.
Okay, so parasternal long and short axis. Parasternal long axis with a focus view on the mitral valve on the right, and on the left, I can see that the left ventricular function looks reasonable with normal left ventricular and right ventricular outflow tract sizes, very thin rim of pericardial effusion. There is a bit of dilatation in the aortic root, but I would like to confirm this from different view and take exact measurements. Left atrium looks within reasonable size. From the mitral valve point of view, I can see that the orifice is decreased in size, as well as there is a pattern of hockey stick appearance over the anterior mitral valve leaflet with a bit of calcification along the leaflet. Aortic valve looks opening. Yep. So this is a colored Doppler view over the parasternal long axis, and this is so I can see a pattern of flame-like appearance coming out of the mitral valve. I can't appreciate any much of mitral valve regurgitation, and there is a tiny amount of aortic valve regurgitation. It will be just like trivial, and no interventricular septal shunting. Now this is an apical four-chamber view. Again, on the right is using the color Doppler, and on the left is just a 2D image. So this again confirming the hockey stick appearance feature of the anterior mitral valve leaflet with normal systolic function. Right ventricle is a little bit generous on this, but I would like to confirm whether there's any tricuspid regurg to
I think I would
reflect
suggest
on.
not to use this terminology, generous, as I say, mild, moderate, or severe.
Yep. So there is at least a mild enlargement of the right ventricle on this view, and I would like to, but looks systolic function is normal. So I would like to identify whether there is any associated tricuspid regurg to reflect on pulmonary pressures. This mitral valve continuous wave Doppler, and this showing a mean gradient of 5, between 5 and 6 on most of these measurements, and maximum pressure gradient of around 12. So there is an element of mitral stenosis, but it would be in the mild to moderate severity. And now this is tricuspid valve. So this is an apical 5-chamber view, and I can't really appreciate where the cursor placed, whether it's mainly to reflect on the tricuspid valve regurgitation, or yeah, it's on the tricuspid valve. So this showing RV, RA pressure gradient of around 26 with peak velocity across the tricuspid regurgitation of around 2.6. So I would add the right atrial pressure on top of that to identify the pulmonary hypertension. So that would be consistent with moderate pulmonary hypertension, moderate pulmonary hypertension, and mild pulmonary hypertension, but it would lie within moderate mitral stenosis severity, between 30 to 50.
But your
depends on the right atrial pressure.
25, 26. So
yeah, it depends on the right atrial pressure. So I need to get the IVC view to reflect on the right atrial pressure, and hence
IVC is 1.5 centimeter well collapsing.
And collapsing, so that would be giving 8 millimeter mercury. So this gives mild pulmonary hypertension of around 35, and that would defining moderate severity of the mitral stenosis between 30 to 50.
Summarize.
So to summarize, this looks like, although she's 69 years old with history of congestive cardiac failure, I think that this rheumatic heart disease with underlying mitral stenosis, moderate mitral stenosis with underlying rheumatic heart disease affecting the anterior mitral valve leaflet.
Only one thing I disagree is that I think it's a mild mitral stenosis, because if you see, most of the pressures were between 4.5 range, and there's no effect of the mitral stenosis. It means that left atrial is normal, and
exactly,
and the pulmonary pressures are normal, almost normal, because I said 1.6, IVC well collapsing, that would be 5, pressure. And so it's around 30-ish of pulmonary pressure, so no pulmonary hypertension. So conclusion: normal LVRV, mild stenosis, mildly thickened mitral valve, and no pulmonary hypertension. Thank you. Who wants to take the next one? It's better to take the cases early, because it's gonna get difficult.
I can do Vishal.
Okay, go for it.
So it's a 69-year-old female admitted with exacerbation of COPD and has got pitting edema, and she is having a transthoracic echo to assess pulmonary hypertension. So what I'm seeing is a parasternal long axis view. Looks very hard to read, related to probably it was a difficult imaging related to her body habitus or her position. And I also see a zoom view of the mitral valve. All I can appreciate is I can see a normal functioning LV. I can see the mitral valve. I'm reading the one on the left side, which shows, I can see a bright spot on the anterior mitral leaflet, possible some calcification there, but I'm trying to correlate how the mitral valve is looking on the right side, which shows the base is definitely not calcified, is more calcification at the tip. And given I'm reading the mitral, I'm looking at the LA, which looks normal from this particular view. And I can't appreciate RV to be big in this view too, which I probably will correlate to look at the 4-chamber view. And it's a color Doppler over in the parasternal long axis view. I can definitely see sort of flame-shaped jet appearing on the mitral valve, but I want to see in other views just to confirm that. And I see on the left side a 4-chamber view. In this view, I can appreciate the left atrium is dilated.
Left side is 2-chamber.
Is it?
Yeah. Oh, sorry. Left side is 4-chamber. Right side is 2-chamber. I mean,
yes. Yeah. So on the left side, I see a 4-chamber view where I can definitely appreciate the LA looks dilated, but I need the measurements to see whether it's mild or moderate. I can definitely see the anterior mitral leaflet tip quite calcified with restricted movement. On the right side, I see a 2-chamber view, which definitely shows a good flame-shaped jet on the color Doppler and indicating there is a possibility there is a mitral stenosis. So I like to do some Doppler studies to see the, so on the Doppler studies, I can appreciate the mean pressure gradient is about 11.93, correlating with a moderate mitral stenosis. I'm also confirming whether the patient is in sinus rhythm. The patient is definitely in sinus rhythm. On the right side,
what's a gradient in terms of severity? Mild, moderate, severe?
Moderate mitral stenosis.
Mild, moderate, severe in terms of mean gradient. What numbers we are looking at?
Oh, sorry. 5 to 10 is moderate. More than 10 is severe. So it's possibly towards a severe mitral stenosis. And then I see on the right side, the pressure half time is 72. So I divide, it's 72 milliseconds. So it's 220 divided by 72. Oh, I'm trying to.
Mitral valve area given, after the calculation.
Oh, the valve area is measured as 3, which doesn't correlate the Doppler on the left side, which is indicating that the severe mitral stenosis. Based on the pressure half time, it's saying it's a normal valve area. So I may need to look at, sorry?
Why is that?
Depends on the angle, how we have done the Doppler study, which possibly looks different from what I'm seeing on the left side. I'm trying to see whether the angulation looks all right.
Always, go those pitfalls of,
we did. The only thing is whether there is an aortic regurg there. Sorry, Vishal?
What's the heart rate?
118. Oh, the patient is tachycardic. Oh, okay.
So that could be the reason.
Yeah.
And other things which you mentioned, because I don't have aortic regurg for this patient.
I couldn't appreciate on the parasternal lock axis. This is more looking at a color Doppler on the right side through the tricuspid valve. And still the patient is tachycardic 117. We're getting a Vmax of 4. So 4V squared, so 16 into 4, indicating more like towards a severe pulmonary hypertension here, which correlates to the severe mitral stenosis based on the mean pressure gradient we have received before. So I would like to see the IVC measurement to decide what's the right heart pressure is and add to get the pulmonary artery systolic pressure, but already it's showing mostly on the severe side of the pulmonary hypertension.
To summarize?
Sorry?
To summarize?
It's a 69-year-old female with COPD exacerbation who has got normal LV systolic function with features of severe mitral stenosis with severe pulmonary hypertension.
We reported it as moderate.
Okay.
The reason being patient, the flow conditions were different, and patient was tachycardic, and the pressure half time and the mean gradient was not correlating.
Yeah.
And the opening of the mitral valve doesn't look like it was severe, because you can see there was decent opening in the anterior posterior mitral valve leaflet. So we reported it as a moderate.
Okay. Though the mean has come on the higher side, Vishal, still moderate mitral stenosis.
So that's why you cannot take one parameter.
Okay.
Based on one parameter, you have to take everything in the context.
Sure.
So Vishal, in this context, how much would be the contribution of the COPD to account for the pulmonary hypertension?
100% to the definitely contribution of that. That's the second reason that you cannot blame on the mitral stenosis for all the pulmonary hypertension.
Yeah.
Again, you need to compare with the previous echoes for that. And who is the next speaker? Do I need to ask someone? Ben, do you want to take one?
Yes, Ben.
Yeah.
Yeah.
What have we got? Okay. 49-year-old pulmonary sepsis and history of CREST. Okay. All right. So to start with, I'm looking at two clips. On my left is a parasternal long, and on my right is a parasternal long with color over the mitral aortic. On my left, looking at this image, so I can see the patient appears to be in sinus rhythm at about 100 to 101, although that might be AF actually, given that rate at which it's flicking. I can see with regards to left atrium, it appears dilated, it's bigger than the aorta. With regards to the mitral valve, I can appreciate what looks to be reduced opening associated with both restricted movement of the posterior and the anterior cusps. The anterior cusp appears to be almost hockey stick in this view, and looking at it here, I'd also question whether this is leading to some potentially dynamic left ventricular outflow tract obstruction. The LV looks to be functioning well. I can't see any regional motion abnormalities in this view, and the right ventricle doesn't appear to be dilated. Looking at the color, so now my right, there looks to be a flame-shaped or styled jet going into the left ventricle from the limited color flow I've got, and the aortic, there appears to be some aortic regurgitation, but I'd like to slow it down to make sure I'm looking at that in the right frame. Switch over to an M-mode view now with the M-mode cursor on the or through the mitral. What I can see is what looks to be severely restricted opening of the mitral valve cusps. I'm struggling to see the ECG trace that's lost in the bottom of the screen. Here it looks like she's in sinus rhythm. They look fairly regular. And it looks like there's severe reduction in the mitral valve opening. The septum appears to be thickened, was moving well. I've now moved over to a apical 4 chamber. On my left, where there's no color, both LV and RV function looks to be normal. The right ventricle looks to be of appropriate size. The left ventricle looks to be appropriate size. And I believe that I'm on axis from this view. The left atrium appears dilated. The right atrium size appears normal. The annulus perhaps of the mitral valve appears calcified or at least partially fibrosed. I'm struggling to see the tips and leaflets on that view though, so I'd like to pan through and try and get a better view of the actual cusps and or the leaflets and tips. On my right now is the color Doppler box over the same view. I cannot appreciate any mitral regurgitation, but looking at inflow into the left ventricle, it appears turbulent. I believe in early diastole, there's more pronounced of a flame-shaped jet. I think I'm getting perhaps a bit of flow through from the aortic. I'm not sure there. So yeah, I think that color view is also consistent with some mitral stenosis. And
what about intervertical septum?
So on the non-color images, the septum appears to be, it appears to almost have a movement from the right ventricle into the left ventricle, which would make me question whether there's a component of either volume or pressure overload, which I find to be a bit discordant with everything else I've seen so far. So I'd like to go back to see the parasternal shorts and see what it's doing in that, with regards to that. Now looking at Doppler. So on my left, I can see that I've got mean gradients in the range of 10 through to 12.6, noting that she's tachycardic throughout all of it. But the traces appear to be of reasonable quality. And now looking on my right, the pressure half time is relatively short. It would fit, so off the pressure half time, it would fit into a mild mitral stenosis category. Off the mean gradients on the left, it would fit into a severe category.
Same problem. So there's a discrepancy.
Discordance here, and off the history of CREST, she's going to have pulmonary hypertension. Well, probably going to have pulmonary hypertension anyway. So I suspect the next screen, which will have the Doppler through the tricuspid valve, will show quite elevated pulmonary pressures. Oh, that's not too bad. So color Doppler on the left, showing TR and noting that she's in sinus rhythm here, remains tachycardic. And on the right, we've got reasonable trace, a good trace, and a max gradient of 47. Obviously, look at her RVC to work out what her right atrial pressure is, but that's still going to have her be presumably low to mid 50s, so it's moderate TR. So in summary, she's got what sounds to be, from the description and everything I've seen so far, more mild or moderate mitral stenosis, acknowledging that her gradients will put her in the severe category, and she's got moderate pulmonary hypertension.
And we repeated this study after 6 weeks because the patient was very tachycardic. And so we said, we need to repeat this study because again, there was discrepancy between the mean gradient and your pressure half time.
Yeah.
So that's after 6 weeks.
Right, okay. So looking here again, parasternal long and a zoom view of the mitral valve, left and right respectively. So her left atrium appears to be of a better size. Looks to be some reduced movement of that, both cusps more to the posterior, I'd say, of that mitral valve. The remainder of her cardiac function at this slow heart rate looks reasonable. Okay. Apical forward chamber on my left. Again, there appears to be increased echogenicity, so some calcification or at least thickening of the posterior mitral valve leaflet on the non-color view, and on the color view.
So there's not much flame shape.
No, there doesn't look to be too much at all. It looks pretty good. I think that certainly the stenosis that we're seeing in the original images appeared more severe than what it does now. Off the numbers now, so she's got a mean gradient of 2.2. So that would be normal. So we've got 2 and functional.
Basically, that's a very good case of functional mitral stenosis. So in the previous, same case, but the previous study, you can see, it was almost severe mitral stenosis. Patient was tachycardic, high output state, and
the difference was just that she was effectively septic, tachycardic, and questionable fluid status, I guess.
When patient got better, we repeated the study. It was almost, very, very mild mitral stenosis.
Yeah.
So you can see, in both the second case and this case, both the cases were the, cases of functional mitral stenosis.
Yeah.
So that's why, this tachycardia and all those, surge phenomena, high output state, it has significant effect on the Doppler studies for the, mitral stenosis.
It's very
so things lightly.
Michelle, from what's your threshold then in cases like that to proceed with the TOE to have a better look at the mitral valve and actually have a look at the opening of the valve?
Yeah,
because
so, the planimetry is the most important finding because it's not dependent on all these things. Yeah. And but whether I would do the TOE just to calculate planimetry, yes, depends on the clinical context. All right. If I'm getting a good TTE and if my patient is not really sick, yeah, then I can wait a little bit because again, the tachycardia would have some component because it would not be easy to see that you can slow it down, but definitely planimetry I would rely maximum on my assessment of the severity.
Yeah, and in regards to hemodynamics, as we know with mitral regurgitation and preload and afterload dependency, when you do TOEs and you'll get completely different numbers on systolic pressures and things. Anything to watch out for in mitral stenosis, or?
Yeah, so if you depends what you're measuring. So if you're measuring your mean gradient, then it has a more effect on mitral regurg. But if you're talking about more of pressure half time, then aortic regurg is the main culprit. So depend which parameter you're measuring.
Yeah.
And now because you're with me, you can take the next one.
Yeah. Sure, absolutely.
Vishal, first, sorry for interruption. It's possible to return back to the M mode. I just would like to ask you a very quick question about it. Do you think that there is an LVAT obstruction from here?
Don't think so, because
during systole it's okay, isn't it?
Yeah, you can see you're open, so it's not the right frame to check that, and it's not.
No, on the M mode itself, on the anterior leaflet, there is no much space on the even on the systole.
So if you see on the 2D, it doesn't look like.
All right.
So M-Mode is not only, it's a good mode, but not should be the only mode to diagnose these things.
Yep. Okay. Thanks.
And the last case, which is very, very impressive case. I've never seen in my life something like that. So that's your history.
Do you want me to take that, Vishal, or?
Yeah.
So female, 64 years of age, known case of mitral stenosis, was admitted with respiratory distress, and a transthoracic echo is done to assess severity of mitral stenosis. Wow. So yeah, parasonal long axis view, we can hardly see the RVOT in this image. The ascending aorta looks normal in size and I've got a massively dilated left atrium. In regards to heart rate and rhythm, probably AF at a rate of 74 to 77. And then we've got hockey stick appearance of anterior and posterior mitral valve leaflet, and due to the probably dilatation as well of the atrium, there seems to be almost seems to be a coaptation defect during systole of the two leaflets. So we're putting some color here through the mitral valve, and there seems to be a mixed mitral valvular pathology with stenosis, but also even with the Doppler angles being perpendicular to the flow region, quite a bit of regurgitation into the left atrium. And since we've got the aortic valve in the image as well, good going aortic regurgitation to be seen as well. Ooh, I just love M-Mode. So ENA, yeah, I'm finding it hard to interpret those images, but there seems to be a gap even during
anterior leaflet.
Yes, yeah.
This is your posterior.
Yeah, so there seems to be a gap in between the.
Yeah, based on this, looks like it's moderate.
Say it again, Vishal.
So based on the M-Mode, looks like it's a moderate stenosis because still you can see a little bit of opening here.
All right, yeah. Right, where are we here? So transthoracal image.
Which view is this?
Well, that'll be the left atrium here, probably apical four chamber with a lip.
Apical four chamber, and that's what we got. So it's full of left atrium everywhere.
Yeah. So yeah, massively dilated left atrium, as you can see, with some spontaneous contrast in the left atrium, resembling low turbulence and low flow. Probably can almost see the left atrial appendix in this.
Yeah, people say that you can't see left atrial appendage on transthoracic echo. It's all you can.
Yeah. Yeah. Is there? What's the line within the left atrium towards the bottom of the left atrium?
That's the boundary of the left atrium.
All right. Mm-hmm. And yeah. Focus on the mitral valve. Again, we can see the hockey stick appearance of the both mitral valve leaflets. Mm-hmm. And doming. Mm-hmm. Yeah, again, that shows mitral stenosis as well as moderate regurgitation that needs to be quantified as well. Looking at the mean gradients with the color wave Doppler through the mitral valve, we've got a mean gradient of 8.16, and so that's all the stenosis, and a mean gradient of roughly 11 on the right image, depending on the stroke volume, I guess, and given the arrhythmia measured twice. Is that correct? Or?
Yeah, 4V scale.
Yeah.
Sorry, and I don't have a few images. So in the first image you commented that there was at least mild to moderate aortic regurg as well, and so that's why you need to think about the effect of aortic regurg on the measurements. So to conclude, so what's the summary?
Yeah, conclude that we're seeing a mitral stenosis from a gradings point of view that would probably be more likely in the severe category. We haven't seen any pulmonary pressure, so upstream effects we haven't examined with a massively dilated left atrium.
Yeah, it was not easy to measure the right side.
Yeah,
it looks like it would be at least moderate. Yeah, and it's moderate to severe category, but if we say based on just the number it's moderate, which definitely would be underestimated, because based on the pressure effects, the pregnant left atrium, definitely it has to be severe.
Yeah, with the features of mitral regurgitation.
Yeah,
and aortic incompetency as well.
Michelle, can I share a quick picture of a similar patient?
Yeah, sure. And I'll just read my final slide, then after that you can share it. Or this. Yep. So to conclude, so basically, whatever parameters you have, you need to use multimodal approach and try to correlate all the techniques in terms of planimetry, pressure, half time, mean gradient. And whenever your hemodynamics, stress test, you need to consider. So whenever your patient symptoms and your echo findings are not correlating, think about the stress test. And depending on what's the morphology of the valve, and that would decide about your interventional approach. So that's the take-home message.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.